So in this video, we're going to look at the skeletal system and some of the other connective tissues that are involved in the musculoskeletal component of movement. And in order to have that conversation, we look at the muscles, and we'll have another conversation about the nervous system, and then we'll look at the connective tissue that's looking at the articular system. But these are the general muscles. This is an image from your textbook, and you should be roughly familiar with the musculature. Remember, we want to focus more on groups and movements. So as we'll talk towards the end of this lecture, we don't want to focus so much on we want to have a deltoid training day or we want to train the traps, but we want to look at the shoulder complex as a whole and look at maybe horizontal pressing in the sagittal plane or in the frontal plane. Now, all the muscles, when we look at the movements that we're looking at here, all attached to the skeletal system, and you should also be roughly familiar with the major bones of the body. And we'll talk about the bones themselves, but we're more interested in the interconnection of the bones, so how the bones form joints and how they relate to each other. And the reason why this is all important is when we look at this human movement system, this here, the movement, is what we're primarily focused on. And we look at this slide here, the movement is dependent upon the articular system. And remember, the articular system is the bones, the connective tissue, the fascia. That articular system is 100% controlled by the muscular system, and the muscular system is 100% controlled by the nervous system. And you also see that there's information being sent back to the brain from the articular system, and information being sent back to the nervous system from the muscular system as well. And the nervous system coordinates, integrates all that activity, creates a motor program that's passed down to the muscular system, that's passed down to the articular system, and that's how we get movement. So the articular system is the focus of our conversation, and it's the skeleton, the bones that we see. And the skeleton itself isn't just the articular system is not just the bones, but it's all the stuff that's connected here. So you'll see this is the articular system. This is just the bones with the cartilage and maybe some of the joint material. And then you can see there's a whole bunch of fascial and connective tissue and a lot of things that sometimes don't get a lot of credit. And this is what we want to consider, because when we look at all the movements that are available to us, that's all happening through this connective tissue. And these movements start with this foundation here when we look at our human movement system through loading through the skeletal system. Now, the skeleton itself is broken down into two divisions. You have an axial skeleton, it's right here down the middle, which is everything is usually a singular except for the ribs, but the ribs are really extension of the thoracic vertebra. And then you have the appendicular skeletal, think of appendages, and that's your arm and your leg, and that's including the pelvic and the shoulder girdles, which are the transition points. Again, another slide kind of teasing out the appendicular and the axial skeleton. When we start looking at these regions with the appendicular and the axial skeleton, we can kind of reduce it down into this image here. And I like this because it shows us just the appendicular skeleton here in the light blue and the axial skeleton here in the gray. And you'll see now that the spine itself can really be referenced as a circle, and that's the connection point, the integration between the shoulder girdle and the pelvic girdle. And you have the upper extremity and lower extremity. And the reason why we start looking at this is as we progress through the semester and as you progress through your academic career, you'll learn that the spine itself, when we talk about the core, is really the transition point from the pelvic girdle and shoulder girdle. And the motor that drives all athletic and human movement is the interaction between the shoulder girdle and the pelvic girdle, and the arms and legs are nothing more than just extension of that. So we'll look through all of our movement assessments. These are the joints. You have the shoulder, elbow, wrist, hand, right? Times two. You got two shoulders, two elbows. Same thing with the lower extremity. And then we start looking at the shoulder girdle and the pelvic girdle as separate biomechanical components, as transitions between here and through the spine. And so this image will pop up quite a bit as we look through many of the movements. And with the appendicular skeleton, we got really into the planar movements of flexion and extension, ab and abduction, internal, external rotation. And now we're going to turn our attention a little bit to the spine. And the spine itself is several bones and joints, but we look at it as a collective. And we look at these collective regions of like the cervical vertebra, the thoracic vertebra, and the lumbar vertebra. Now, these are numbered L1, 2, 3, 4, 5, and T1, T for thoracic, C for cervical, and L for lumbar. You also have your keystone here, the sacrum, which at one point was 5 individual vertebrae, but they were fused. And same thing with the coccyx. This was 3 to 5 different bones that were also fused. And so you have one tailbone with coccyx. You have the sacrum, and then you have L5S1, L4, L5, and you have this interrelationship all the way up the spine. Now, what primarily separates these regions are these curves that you can see. So you have these concave and convex curves. So you have a convex curve here. So it kind of has a point coming out like a hump on the back. And then you have a concave. It kind of caves in if you're looking from the side. And this is the front, it's anterior. This is posterior of this view here. These curves serve different functional purposes. And it's the interrelationship of this concave, convex, concave curve that helps us with biomechanical function. Now that's advanced. What you should really focus on is that you have a cervical region, which is looked at one functional joint, a thoracic region, which is looked at one functional joint, and a lumbar region, which is looked at as one functional joint. But appreciate that there's 5 vertebrae here, 12 vertebrae here, and 7 vertebrae here, and they're named accordingly: C1, C2, 3, 4, 5, 6, 7, T1, and then you have your transition points between cervical thoracic and thoracic lumbar. Another image that kind of shows the different regions here, and you have your parts of your spine, which are the foundation of your core. The thoracic vertebra and the cervical vertebra are the transitions into the shoulder girdle, and the sacrum with some of the lower lumbar vertebra are the transitions into the pelvic girdle. So like if you see here on the side here, here's the sacrum, you would be looking at, this is where the pelvis connects. And so the pelvis would be blocking probably all the way up to L4 here, L3, L4. And where the sacrum goes, the pelvis goes. And where the pelvis goes, the sacrum goes. Where the sacrum goes, that pulls and that puts the position for the lumbar spine. Where the lumbar spine goes to thoracic, and you can see the domino effect that occurs. Now, all bones have metabolic activity, and you have breaking down and building up of tissue for remodeling. And that's really what's happening with the bones, is that they're constantly remodeling based on the stresses and loads that are being applied to them. And the bones themselves are deposits or storage sites for hard minerals, particularly calcium, magnesium, and so forth. So you have osteoclasts, the first one here, which is the breakdown. And the way that you remember this is C for catabolic, so things that break down. And osteoblasts are the things that build things up. So think of B for building up, so anabolic type aspect. And it's really a constant process between these two things, where osteoclasts are breaking down the old tissue to kind of gain those materials. And the example that I use a lot is thinking about Legos. And you have Legos that you've built, and when those osteoclasts break down bolt tissue, they're not getting rid of it. They're just taking something you've built and breaking the Lego pieces down into the smaller pieces. And the osteoblasts are coming in and then taking those pieces and remodeling them into a new thing based on the needs and demands of the tissue. In children, the osteoblast activity are way active, so you can have a fracture or some kind of injury and fully recover from that. Your bones are very strong and can handle loads. As we age, osteoblasts kind of calm down a little bit, osteoclasts become more active, and that's when we lead into, if we're not doing a lot of activity or not a lot of loading, we get that bone density issue where you're getting too much breakdown and not enough buildup. So here's your anatomy of your long bones, and what makes this unique is that you have a long shaft, and then you have two ends. You have a epiphysis on either end, and then you have a diaphysis in the middle. And then the key point here is this epiphyseal plate, and this is the growth plate. And you have your compact material here, your bony solid material, and you have compact bone and cancellous or spongy bone, but still relatively dense and firm. You have empty space here in the middle, which is filled with fat and blood vessels. This is where red blood cell production is occurring. And then you have this cartilage and connective tissue both at the end and right here at this epiphyseal plate. And it's at the epiphyseal plate where we have our bone growth. And you can see here that the bone growth goes longitudinal through the long axis of the bone, but it doesn't come in on the end. This is fully formed because this right here is a joint, and this up here is a joint. And so you can't really change much through the joint capsule, through the joint and the cartilage. What's happening is you're growing from inside out. And so you have new tissue kind of spreading out here, if you will, and that spongy tissue turns into firm tissue and then eventually hardens from osteoblastic activity. and becomes solid new bone. And so the bone length changes in this longitudinal direction. Injuries that occur through here, and you can kind of see this here again, the epiphyseal plate. You can see how the bone reabsorption and how it grows this way, not by adding on the outside here, but kind of growing from inside out. But if you end up with a fracture or break that goes right through this, this is cartilage, this is soft tissue, and this is bony tissue. And sometimes in the repair process, the body will lay down. Think of a scar tissue, like the scar when you cut your skin is thicker and more dense than the normal skin tissue. That's sometimes you're at risk that if you fracture a bone and it goes through the growth plate, you've stopped longitudinal growth now, at least at that side of the bone. So that's when you end up with issues, and you might have to go for surgical repair or something to that effect. But for the most part, a bone break or fracture happens, and the bone reheals, and sometimes you don't have any evidence of it at all. So bone responds really well to loading, like all tissues, but it responds particularly well to this rapid loading and unloading. And it does so better than total load. So like for instance, for muscles, if you put a certain amount of weight on, like 100, 200 pounds, your muscles have to generate tension to hold that, and that increased muscle tension, dependent upon load, so the greater the load, the more the muscle tension, that stimulates new muscle growth. With bone, it doesn't really matter the total load. So whether you put 10 pounds on or 1,000 pounds on, your bones are going to respond a little bit, and then that's it. Like there's a little bit force or stress lines. What needs to happen is this compression, decompression, or this oscillating like vibration where every time you take a step. So picking up a 5-pound weight and then putting it back down, picking it up again. So that compression, decompression, that loading, unloading, think of it like a sponge. That's what stimulates more of the bone growth. And, in the 1980s, actually even earlier, 1940s, 1950s, you had these belt machines that were meant to be for fat loss, but they were actually really good for bone loading. And this technology really hasn't gone away. It just changed a little bit. And you'll see now a lot of this vibration-based training. And there's different reasons why you would do it. The vibration itself can overload the neuromuscular system for the stability and force the muscles to do a little bit more work. It does create that rapid loading, unloading. So it creates a more dynamic environment. And so the vibration training, whether it's like the Vibe plate or the Power plate, these are the two most popular. This type creates a different type of stimulatory environment, and you're meant to do different exercises on it. So doing a squat on solid ground versus doing it on something that's rapidly changing changes the environment, both from a neuromuscular perspective and from a musculoskeletal perspective. And if you still wanted to, I guess you can find some of these belt trainers. And the logic on it was somewhat sound. Like for a squat done on a Vibe plate like this Vibe plate, you're going to probably have to work harder for the same amount of activity. So you actually are burning more calories. Now, just sitting there and just letting it do its thing, I don't know if that was really effective or not, but doing it in conjunction with movement, this vibration training is not bad. Now, this technology is being revitalized, if you will. And so you're seeing some more modern aspects of these machines. You can see that there's some like soft tissue, myofascial release stuff integrated into it. So I don't know, kind of fascinating. These are the Walton machines, or the old ones back in the day. And there's some aspect to it. But if your club happens to have a vibration machine, we have one in our facility. I would try it and see. And just the mere act of just standing there physiologically should be stimulating bone better than just standing there on dry ground. Now, you can have too much bone growth, and you can get inappropriate bone growth. Now, bone responds to load. It responds to stress. So if you put stress or force on a bone, it's going to respond accordingly. If you put too much stress or abnormal stress, that like right here where you see these bone spurs, that's where there's been extra load coming on, and the body's just doing what it's supposed to do, which is, hey, I'm pulling on this more often. I'm going to reinforce this with more connective tissue so that it can handle those forces, handle those loads. When you go in there and just kind of shave that off in an orthopedic surgery, if you never address the muscular imbalance or the abnormal loading that was pulling on this in the first place, this is most likely going to come back. Conversely, if you address the muscle balance and you restore normal balance, you have constant bone remodeling. You have osteoclastic and osteoblastic activity. And so if your bones will deteriorate just from not doing anything, same thing's going to happen when you take that load off. That bone's going to remodel back down. And so sometimes bone spur, if you haven't had any other connective tissue damage, sometimes that bone spur can act as a a friction point, and you start to get tendon wear down and other tissue aspect. But if you change the mechanics, the bone spurs should reabsorb. So that's why you want to consider in terms of the things you're doing with your clients. Are you doing the same thing over and over again? Or are you creating variety so you're not getting this abnormal bone growth? So we started the conversation looking mostly at classification, at movement, and in order to have movement, all movements happening at the joints. And if you in your textbook, you'll see that joints are classified, and beyond just like 1 degree, 2 degrees, or 3 degrees of freedom and planes of motion, which are important, but the structure of the joint and the shape of the joint is what really determines the degrees of freedom. But you have different types of joints. So like your vertebra, the symphysis type aspect, are going to be different than the synovial joints that you have here at the elbow and the knee. And it really comes down in terms of function and how they're operating. Most of the joints that we shared in that little list, the elbow, knee, ankle, and so forth, these are called synovial joints. And they're called synovial because they have a joint capsule. So you have the two bones coming together. This is the contact point here between these two bone surfaces, and you have articular cartilage, which acts as like a lubricant, a frictionless surface, and shock absorption. And then all of this is contained. You have fluid in here. You have synovial fluid, and you have a synovial layer, and it makes this really tight capsule that nothing really can get in. And then on the outside of that, you have more connective tissue, joint connective tissue, and then you usually have some kind of ligament structure that's keeping these two bones together. So this is what we're dealing with, and when we look at, when we're putting loads or having things move, we have to take in consideration all of the tissues that we're loading in the body. A lot of times in your reading, you'll hear this thing called the kinetic chain, and this is really talking about this aspect of regional interdependence. And it's important to appreciate that when you're looking at the human body, there are multiple joints or links in that complex, and you can have like a biomechanical aspect, or you can have a tissue aspect, or a muscular aspect. And so it's really thinking of the human body, these kinetic chains, as dominoes. One is connected to the other, and one will have an effect on the other. Some people with this regional interdependence, this term regional interdependence here, you have to be specific on what you're talking about. Are you talking about joint-to-joint relationships through the articular system? Are you talking about muscular, like muscular relationships in terms of this muscle, then this tendon kind of incorporates in here and has a biomechanical aspect? Are you talking about fascial relationships? So the connective tissue through the shoulder complex, is it integrating down into the rhomboids and around on the other side into the serratus anterior and then into the external oblique? So and the reason why I bring this up is that you have some people that say, oh, regional interdependence isn't a thing, and some say it is a thing, and it all depends. If you're telling me that the fascial relationship down in the toe is affecting the hip, that's a pretty solid argument, right? And you can actually make the same argument neurologically and fascially all the way up from your right hand down to your left foot. But now if you're talking about like a biomechanical aspect, that joint movement at the foot can affect the elbow, you might have a lesser of an argument, but you're not wrong. It's just that you're talking about the wrong tissue. So again, thinking of the body in terms of the dominoes and these chains and these links and how they're all interconnected. And we come back to this image here where you have your upper extremity, your shoulder girdle connected to your spine, and that's related to your spine is related to the pelvic girdle, and the pelvic girdle lower extremity, and you can start to see these patterns or these paths that are coming through the body. And so you start looking at the body in terms of these chains. So you have like your ankle, your knee, your hip, through your spine, up through your upper extremity and down. And what can happen is if you get out of whack in one area, it starts to set the domino effect off, and you can start having these interrelationships all the way up the body. And so when you have movement or lack of movement or abnormal movement at one joint, it can definitely affect the position, the mobility, or the stability of the joints up the chain. And so you can kind of see here that as you flatten the arch, that creates an internal rotation at the knee, that creates internal rotation at the hip, which creates adduction, internal rotation, and like a pelvic drop. And then that changes the angle of the sacrum, and then that changes the lumbar spine requirements. And so you might not have any visible postural distortions, you most likely will, but you can just have more mobility now. So if I drop this hip down, that's creating lateral flexion at the lumbar spine. So I'm shortened on this side, lengthened on this side. Now these muscle length tension relationships are different. And not that it might not affect anything right away, but when you're chronically shortening on this side, you start to get tighter. You can start to see that something here can start to affect things all the way up the body. And so when you're investigating why someone's knees diving in the squat, or why someone has shoulder pain, or it might not just be a local issue, but you might have to start tracing the mechanics back and start tracing those chains down the body. When we look here of how we truly have these interrelationships, is that all human movement is based on two fundamental things: the aspect of standing, and then walking, and the advanced walking is sprinting. And what I want to point out here is that when you look at a normal human gait, and I use this because it's exaggerated out of the starting blocks, but this is basically what you see is you'll see flexion down the right lower extremity, and you'll see an equal amount of flexion in the left upper extremity. And you'll see extension through the right lower extremity, and you'll see general extension or overcoming gravity in the opposite right upper extremity. So left leg, right arm is interconnected or mechanically related to the through gait through the spine. So leg through the pelvic girdle into the spine, and through the opposite arm and contralateral limb. So there's definitely a connection there. And when you look here, again, you look at the gait, this is the segments we want to look at. You see right leg, left arm coming forward, right arm, left leg going back. And so you have this extension through, right? So overcoming gravity. And then you have an opposite collapsing with gravity. And so you have general supination coming through here, down through the spine, down through here. Then you have general pronation collapsing with gravity through the opposite. And then this switching back and forth, back and forth. And the shoulder girdle and pelvic girdle are rotating, and the spine is acting like a battery, the core here, to transfer and generate that energy. And so this becomes the true definition of the core, and it's the interaction of the pelvic and shoulder girdles, but it's dealing with this mechanical relationship between upper extremity and contralateral lower extremity, and vice versa. And so when you are then trying to observe something or teach something or fix something, you have to be considered about how things can interact. And so if you start to see things that are offline, off tilter, it might not be a shoulder issue, but it might be coming from here. And what's neat is that you intervene at any one of these points in the chain, it's going to have an effect and might be the effect that you're looking for. So it's something to keep in mind in your future clinician or interventions. So last thing we're going to look at is the joint connective tissue. And so we looked at this slide here where we saw the articular system in its full, and this is just the bones, and this is looking at the connective tissue that's there. And we have three primary aspects, and this tissue is all made up of the same components, all this collagen-based structure that's meant to resist and transfer forces through the body. And so you have your muscles, which you see here in this slide here, the muscles kind of integrate and turn into this matrix here, this musculotendinous junction. And the muscle doesn't turn into, but it interacts with tendon. The fascial relationships of the muscle, like all this connective tissue here that's wrapping the muscle fascicle and the fiber and then the bundles, that's all continuous with this tendon. You just have contractile elements here and non-contractile elements here. That's why this is usually depicted in red and then white. And then this connective tissue is continuous with the bone, not the bone itself, but the bone has its own layer of like connective tissue. Think of all of the structures being wrapped in saran wrap. So all of your individual muscle fibers are wrapped in plastic wrap, and then these are wrapped in plastic wrap, and these are wrapped some more, and then this is wrapped. The bones are wrapped in plastic wrap. All of that plastic wrap of the body is all connected. It's all continuous. So it's not like the muscle is just attached here and then boom, it's right there, and then it separates and then separates there. The connective tissue, the non-contractile, the stuff that's containing everything together, it is continuous. And then the tendon doesn't just like snap right into the bone there. It's pulling on the entire envelope of that bone. So you have all this really intricate and interwoven connective tissue. And this is where a lot of the manual therapies and movement therapies are moving towards, is this whole fascial relationship. Tom Myers has a book called Anatomy Trains, and he popularized it more recently, but understanding this interrelationship of the body has been going on for centuries. Muscles, they connect to the structural system through tendons, and so you have a musculotendinous junction. And then whenever the muscle contracts and is generating force, it's transferring that load to the tendon. So whatever the muscle's being exposed to, so is the tendon, and so is the bone. You have other connective tissue like ligaments that connect bone to bone. So these are non-contractile, but they're made up of similar material, maybe different ratios of different proteins. So here's your tendon that's connecting muscle to bone. And then here's your ligament that's connecting bone to bone. And then underneath this, what you're seeing is the end of the femur and the top of the plateau of the tibia there. So you're seeing that dashed line. You have the joint capsule that's also connected there. You have your connective tissue there. And so the next slide here looks at here's your joint capsule, here's your ligament on the outside, here's your cartilage. All of this stuff is made up of the same thing. But the thing to keep in mind is that when you're putting load through here, it's not just the muscle that's being loaded. It's the muscle and the connective tissue, and you have to be responsible for that in your program design. Now, the best way of looking at this is that tissues that have the most blood flow have the best opportunity for recovery. So they're going to recuperate the fastest. And then when you have decreased blood flow, either because of injury or because of just anatomical design, you're going to need more time to recover. And so when you look at the line here at the bottom, this is ranked in order of the most vascular, meaning who's got the best amount of blood vessels going there, thus bringing blood resources, and who's got the least amount. And you'll see that muscle has the largest blood flow because it's a metabolic hog. It takes lots of resources, and so it needs a really efficient delivery system to get resources there for working muscle. That same network of supply delivery also is involved in bringing materials for repair, taking out waste products. And so rarely do you have long-term muscle injury. A lot of things that require surgery or recovery are going to be more at the tendinous aspect or at the ligament perspective. And then when you end up having issues with movement like arthritis and joint inflammation, and muscle can recover just fine, right? Bone can recover just fine. Tendon a little better, a ligament a little worse, and then cartilage is the least restrictive or least recuperating because it doesn't really have any direct blood supply, right? When we look at the joint capsule here, the blood vessels come in here and then it feeds the underlayer of it, but the part that's actually being beat up, there's no blood vessels that are penetrating into this joint capsule. It's all coming right up to the top of the bone here, and that's it. So cartilage actually gets its nutrients through a whole different process. So when you are putting load on the body, when someone's lifting weights, doing squats or doing bench press or doing rows, whatever exercise, it's not just the muscles you're training. It's everything connected in that chain that is also being under load. And so when you do your next bout of exercise or how you design your exercise, it doesn't matter if your muscles are ready, are your tendons ready, are your ligaments ready, and then are your joints ready. And so this comes into how much volume you're doing. Are you training 7 days a week, 5 days a week? How many miles you're running or swimming? And one of the things we want to do is really intelligent program design. We want to work smarter, not harder. So when you look here on the left, you see the anatomy of the shoulder girdle. You have your anterior deltoid, middle deltoid, and posterior deltoid stuck behind there. But if you're doing a chest day, it is impossible to do any type of horizontal pressing or flexion or any kind of pushing forward that doesn't involve pec major and anterior deltoid and the anterior half of middle deltoid. And then when you're doing rowing activities or any kind of flying or rowing, it's impossible to train your lats, so shoulder extension or horizontal abduction, without involving your posterior deltoid or the middle half of your medial deltoid or the posterior half of your medial deltoid. So there's redundancy a lot that you'll see, and this is a byproduct of bodybuilding where you had an arm day and a shoulder day and a chest day, and you train body parts, and we're not bodybuilders. And bodybuilding is a sport, and it's a unique sport that has its own set of rules. And sport is sport, and fitness is fitness. And with fitness, we don't want to focus on training muscles so much. We want to focus on training movements. And so when you're training shoulder flexion or horizontal adduction, that already includes your chest, your deltoids, part of the deltoid. And then when you do your pulling activities, instead of like shoulder extension or horizontal abduction, then you can isolate more the posterior half of middle deltoid in without having to do an extra arm day or a shoulder day or a chest day. If you think of some of these bodybuilding splits, they have a chest day, a back day, an arm day, a shoulder day. So you just hit shoulders, these little tiny muscles right here, 4 freaking times, right? What's going on with that's the muscle itself. What about the tendons, the joint capsule, all the connective tissue that's there, it's being loaded up. So less is sometimes more, and more isn't always better. So that's it for the structural system of the body. Again, the textbook is looking just at like bone and a little bit of bone anatomy and joint. But I think with the practical application of connective tissue, that's the big takeaway of appreciating the regional interdependence, where a foot issue might not be a foot issue, and appreciating the recuperative ability of those connective tissue, meaning that it's not just the muscles you're loading, but you are responsible for everything else that's under in that chain.